In this video, I am going to talk about the cardiac myocyte action potential curve, not to be confused with the nodal action potential curve, which has many significant differences, and the test will like to trick you, and you can get easy points if you master the differentiation of these two. So let's start off with what is the cardiac myocyte potential curve? Well, simply um, the cardiomyocytes are electrically coupled to each other by gap junctions, and we have a phenomenon called calcium-induced calcium release. We need calcium to repolarize the heart. Um, I always hated repolarized depolarization terminology because it kind of confuses me, because you think depolarization, it's depolarizing its contraction, but it's actually not. Repolarization is the contraction phase, and a good way to remember that is, you know, this is your time axis. So repolarization is phase 2 and 3. So you know that as the heart contracts, repolarization is the contraction. Depolarization is when the ventricle relaxes to get ready for another heartbeat. So let's start with 0, phase 0. Phase 0 is the rapid influx. It's the sodium fast gated channels, rapid influx of Na+. So the the pacemaker of the heart tells the heart that it's time for another contraction. So it triggers the sodium fast gated channels to open rapidly. That's phase 0. Phase 1 is pretty low yield. It's just the initial repolarization. We get a little K plus efflux, and that's just to help uh, to to help get the positive charge out of the cells, so all the calcium can come in. Um, because there is a phenomenon that I believe I just described, but we have calcium. Calcium is required to contract the myocytes. And I'm going to add in here, because this is different from skeletal muscle, the calcium goes from the extracellular fluid to the cytosol, where the calcium is coupled to GQ protein coupled receptors, which allows the myosin to get out of the way so the sarcomere can contract. That's that part. And then once that happens in the cytosol, it finally reaches the the sarcoplasmic reticulum of the cardiac myocyte. So that's an important concept to know. Different from skeletal muscle, the calcium does not go through the cytosol in skeletal muscle contraction. It goes straight from the extracellular fluid to the cytoplasmic reticulum. So we got all this influx of sodium, this rapid influx of sodium to reach the threshold action potential. Now the heart, the left ventricle is ready to start contracting. You get the plateau phase. So basically, what this Ca2 plus induced Ca2 plus release phenomenon is that the more Ca2 plus that's released, the more it triggers release to allow the most synchronous contraction possible, because ideally you'd want the heart to pump it all at once, but it takes about 200 milliseconds um, to release the cardiac output. Um, in phase 3, once you've got all your cardiac output out, that's when you get the K plus. That's when you get the K plus efflux here. The calcium channel closes. Um, you get some chloride efflux. Uh, Chloride influx to help get the positive charge out of the cardiomyocytes. And then you go into your resting phase, which is mediated by potassium leakage. And it stays here for a little bit until it's ready for the next contraction, when it receives the signal from the nodal pacemaker that it's time for another contraction. Uh, so, how do antiarrhythmic drugs work? Class 1 A, B, C affect the sodium channels. I'll talk about that later in pharmacology. Um, we got class 2 drugs, the beta blockers. Um, we got some lazy man antiarrhythmics like amiodarone. Um, that's all in pharmacology, but basically the way they work is they either decrease the slope of the sodium influx or increase the effective refractory period. Because in atrial fibrillation, what's the goal? Rate control. Pretty complex topic. I hope you found it useful. Please, any comments, corrections, questions, please share with your friends if you enjoyed this video. And I look forward to seeing you again.